Okay. Well, thank you so much, Dr. Cervantes, for joining us today. We're really excited to hear about your talk and more about your specialty and you and your journey. So you can go ahead and share your screen now if you're ready.
Thank you for having me. The screen is intentionally blank. I don't have slides. I have some talking points, and I'm just gonna write some stuff down while I talk. It would be nice if this were a little bit more interactive. My understanding is that, I'm happy to go over some talking points, but I have no time constraints this evening. I'm happy to stay and answer questions and have this be as interactive as possible. So I can get started. First, I also have the chat open. Happy to monitor questions. Like, feel free to throw in questions as I'm talking. I have no problem with that. I was gonna start with an intro. Why peds? You can kind of consider this like a whiteboard or something. Um, in the general questions that were given to me as like potential prompts for talking points, I was specifically interested in talking about misconceptions in pediatrics. I'm going to talk about burnout a little bit, some general advice, and that's pretty much it. So I can start with my intro. As a brief overview of my path, I guess an intro to myself. You can also call me Ollie. Um, I guess at this point I am kind of used to being called doctor, but Ollie is totally fine, especially in this community here. Um, I was born and raised on the East Coast, New Jersey, New York. I went to Northeastern University for undergrad. I studied biology and math, and then I took 2 gap years. I worked in a lab in Boston before moving out to San Francisco. I went to UCSF for medical school from 2018 to 2022. Um, and then for 3 years after that, I just completed my pediatrics residency from 2022 to 2025. So, as many of you know, it's a very long path. Right now, I'm one of the 4 chief pediatric residents at UCSF. Also, um, I'd really appreciate if people threw into the chat like what level of training they are. You don't have to be super specific, like undergrad, if you're in your gap years, like before any graduate school, if you're in a PhD program, or if you're in med school or if you're a resident. I really am a fan of tailoring teaching, talks, etc., to my audience. So I would appreciate that. And thanks for everyone for participating in advance. So now I'm just going to talk about why pediatrics. Um, so I was originally thinking of going into adult medicine, like internal medicine, and possibly a subspecialty of internal medicine, such as such as geriatrics or oncology. It was my labor and delivery rotation, my 3rd year of med school, where I worked with babies and new parents, and that really uh, opened up doors into, I don't know, an area of medicine that I was a lot less familiar with. Um, let's see. I love babies. Babies are, I like, they're so cute. There are a lot of reasons why I think newborn care is very interesting to me, and I think what drew me towards it. Um, so they're cute. I think I just mentioned that. The physiology and pathophys of newborn care and what you might see in a NICU or neonatal intensive care unit is very interesting. There's a lot of interesting medicine that goes on in the NICU. There's some procedures. I'm just gonna delete that. There are some procedures in the NICU. It's kind of adjacent to like OB, which I really enjoyed in medical school. But as many of you may know, OB-GYN is much more of a surgical subspecialty. It's also very, I mean, it's very different from pediatrics, but OB specifically is adjacent to NICU, and I really like that aspect of care. And probably most of all, I really like working with new parents. I can't say that I knew that about myself before medical school. It's something that I guess I discovered about myself throughout my rotations. And for those of you, let's see, I'm seeing at least a few med students. For those of you who have done your rotations, rotations are really when you learn what the day-to-day life is like of a certain specialty, right? Like maybe you like the OR, but how many hours and how many days of the week or month can you actually like tolerate in the OR? Or, excuse me, or maybe you're meant for that. And that's the point of rotations. So that's kind of why pediatrics, there's really more to say there. Um, but I can talk more about that if any questions come up, especially as it relates to like choosing between fields or anything like that. But I think that's a segue into some misconceptions about pediatrics in terms of working with parents. One thing I wanted to talk about was um, when I knew I was going into pediatrics, I was telling a lot of people, right, like friends, family. One of the most common, um, one of the most common responses, um, one of the most common responses I got when I said I was going into pediatrics was like, maybe like a brief pause and like, oh, like, ooh, you're gonna have to deal with parents or something like that, like something to that effect, right? Um, Actually, maybe might be better if I list this out. Working with parents. If anything, having done a 3-year pediatric residency, working with working with parents has seriously only made the job easier. You're going to be talking to adults no matter what, whether the adult is your patient or whether the adult is a parent or caregiver of a child. Um, and I can get into more details about comparing the two, but really it's like, I don't know. One of the main differences is that I found it much easier to form a partnership with parents or caregivers of a child. Much easier to form a partnership and get on the same page because you all want the best for this child in front of you, as opposed to adult medicine. And I don't want to like throw shade at adult medicine, but I found it really challenging to work with many, many adult patients during my rotations in medical school for various reasons, very often for very good reasons too, very valid reasons, but still very challenging. Um, and compared to pediatrics, when looking at working with parents specifically, it wasn't nearly as difficult. Um, Plus, working with new parents is so much fun. It's a happy time. There's a lot of happy stuff in pediatrics, and I'll talk about that in a moment too. Another misconception is that the same principles of medicine apply, um, slash, there's medical complexity in pediatrics. I actually had this misconception in medical school. When I thought about pediatrics, I pictured like child checks, right? Like those regular checkups with mostly healthy kids, parents with questions about some random thing that doesn't matter too much for their child's health. And they could do it, they maybe not. I don't know. It doesn't make like a huge difference. Like those are the kinds of things that I thought about when I thought about pediatrics. And it's not all like that. For those of you who have done rotations in medical school in your like inpatient pediatrics rotations, um, kids can get sick too. There can be some really confusing, some really rare things too. And I thought that there was a really like still intellectually stimulating amount of medicine in the field. Plus, after residency, because of course, like during residency, you're going to have to do all major subspecialties of pediatrics, um, including the more straightforward, like outpatient well visits. But after residency, you can choose to be like in an inpatient setting or in an academic setting where there is the complexity that you might be looking for. Um, the last thing I wanted to talk about in terms of misconceptions was I just mentioned, right, like working with parents, it can be a very happy time. Um, this is a very big and a very difficult topic, and I'm happy to talk about this more later. But not everything ends well in our field as well. Um, and it's not all healthy well child check visits. And so there's this huge, like, emotional aspect of caring for sick children, and working with the family, that personally I find very, very gratifying. I know that it might not be for everyone. I remember some mentors and attendings during medical school telling me like they were choosing between a couple of specialties. Maybe pediatrics was one of them, but they actually chose to steer away from pediatrics because it was too sad, which at that time I found very interesting because, again, I had this like misconception that um, it was all like, like healthy kids in an outpatient setting. You're just like struggling to get families to give vaccines and stuff like that. But, that's just one part of pediatrics. So I can talk about this a little bit more later. I think it deserves more thought and discussion, but I just wanted to mention it here. That kind of links or connects to my next topic, which is burnout. This was another one of those questions or possible prompts. And I think, let's see, before I talk about this, I'm going to address this question. Thank you, Katrina, for asking this. I did not consider med-peds, at least not very seriously. Um, Med-peds, for those of you who don't know or are less familiar, because I know there might be some undergrads here as well, um, the med part of med-peds refers to like internal medicine or adult medicine, general medicine. Peds is, of course, the pediatric part of that. And it's a combined specialty that where most med-peds practitioners end up um, going into like an inpatient setting. And I didn't really know if I could. I guess the short answer to this, or my own response to this, is that I didn't know if I could fully like utilize training in med peds for what I wanted to do long term. I was already leaning towards the peds part of med peds by the end of medical school. I did go through like I think I had like one night of like anxiety and kind of existential um I wouldn't call it a crisis, maybe like one or two tiers below a crisis when I was like, oh shoot, like I'm not gonna be caring for adults anymore. Um, all that knowledge, right? Like all of that studying and like all those rotations I did during medical school, like where's that gonna go? Like, am I just not gonna put it to like is it not gonna be useful to me anymore? That lasted for like one or two nights. And it was fine, and I don't regret this decision one bit. I think taking a step back, a bigger answer to this question would be like, um, I would encourage a lot of self-reflection and what you want out of a job long term. And does this or does any particular path get you there? And will it fill your cup? And maybe I would have been happy as a med peds attending, but I felt more strongly that like it was a very personal decision why I ended up choosing pediatrics. I hope that answers your question. So, related to burnout, I wanted to connect this last bit about there being sick children and not everything ending well. Um, Maybe this could go under misconceptions too. So burnout, burnout is a huge and complex topic. Um, Maybe something interesting that y'all might be interested in looking up is something called the Maslach Burnout Inventory or MBI. It was developed by I forget, psychologist or psychiatrist at Berkeley. I guess a psychologist maybe, together with one other person, and it's kind of the more standardized way that researchers measure occupational burnout, and a lot of it has to do with like depersonalization, like lack of compassion, your reaction to things in your daily life. Um, and this connects to this topic of not everything ending well in pediatrics because I would strongly argue that this, about there being sad things in pediatrics too, um, helps me avoid burnout, actually. And so maybe that's why I could also put it under misconception. So what I mean by that is maybe I can give a couple of examples. Many of my former classmates in medical school who are now either practicing attendings or have pursued fellowship, let's say those in adult care or who went into internal medicine, they deal with death and dying a lot more often. I mean, it's not unexpected. That's the nature of the field, right? Your patients, adult medicine patients, are on average, of course, much older, and you get much older adults too, where end of life might not be or might be more expected, right? Um, those former classmates are around, find themselves in those situations so often that um, those sad things that we see in medicine, death, dying, decrease in quality of life, those really sad stories, it kind of makes them numb to it a little bit. Um, I would say that's a normal reaction. We're all human, and I'm not saying that I would be able to handle it any better. But in pediatrics, to tie everything together, my point is we see sad things far less often, and it makes those times really stick out, and it makes those times memorable. And maybe one thing I can confidently say is that I remember every every death of a child that I've been a part of over these last few years. And for those in adult medicine, I'm not so sure that they can say the same thing. It helps me hold on to what's important. It offers a very unique and reflective perspective on life that I wouldn't replace with anything else. And I think pediatrics is very special that way. So, um, let's see. I think I have maybe 4 or 5 minutes. There's a lot to talk about here. Again, burnout is a huge topic. If I had to tie everything together, I would say that choosing pediatrics, or maybe taking a step back, choosing a field that I felt like I was meant for really helped avoid burnout. Okay, I'm gonna say that I'm actually okay. Maybe we can move on to general advice. And I'm just gonna put this here as well. So, um, choose. Let's see. I don't know how to say this in like a more general way. Assuming everyone here is kind of like on the path towards medicine or already in medical school, choose a specialty that means a lot to you, I guess. It's a really vague kind of generic piece of advice, but in order to like relating this back to burnout, it's so important that you find a long-term job that that fills your cup, that you look for where you look forward to going to work. And that's not always the case for residents and unfortunately some attendings. Um, but you have a lot of time. Hopefully, many of you have a lot of time to think about that. Kind of going along that path, think about your long-term goals. For many of us on this path, there's like always something new to do every few years, right? Like undergrad, you have a goal. Um, I don't know, maybe it's like getting a specific job for some gap years or like going straight into graduate school or medical school. Um, and then once you're there, it's like getting into that graduate school or medical school. There are these like steps in the process. There's residency, maybe you go to fellowship, maybe you do some more training or something like that. But then you have the rest of your career, and you're going to be doing that presumably longer than you have ever trained or longer than you were ever in school. And it's so important to find something that is very fulfilling to you. I can talk more about that too if y'all have questions about that. The last piece of advice maybe I would say is communicate your interests, and then maybe I can like stop after this. So, what I mean by this, I can give you a specific example. Something that comes to mind is a personal example. Uh, so I like babies. You all know that. Um, and my co-chief, her name is Emily. She knew that from a while ago, that I was interested in neonatology or working in the NICU in general. And she connected me to someone she met when she was talking about job prospects after our chief year. Then she connected me with them. I had a meeting with them, and they connected me to a hospitalist in the South Bay. Um, and they connected me to the director of the pediatrics department there. There's a lot of care for newborns there. There's also other things to do. I won't get too much into the job description. But connections become more and more important the farther along you get. Um, I know maybe many of you have like heard that piece of advice before. Like maybe it's like it's not what you know, it's who you know. I really to be honest, I really didn't like that piece of advice growing up, like early in my academic and professional career. I wanted to work hard and kind of like start from scratch and like earn things myself. I guess maybe there was like a sense of pride there or something like that. I don't know. But it is true that the farther along in your specialty and subspecialty you get, the professional community becomes a lot smaller. The world of pediatrics, the world of neonatology, newborn care, subspecialties, like the world is very small, and connections matter. And so just communicate your interests to peers, to your mentors. You never know when something will work out in your favor. Excuse me. I'm going to stop there. And I welcome questions either in the chat or feel free to unmute yourself. I will probably leave around like 6 p.m. PST, and I'm going to share my email here. Actually, it's probably easier for me to type this in the chat too. But thank you for having me, everyone. There you go.
Hi, Ollie. Thank you so much for being here. Oh, sorry, Raven.
I'll
Didn't
go
mean to
ahead,
talk
Ellen.
over you. Um, I don't know if it's gonna dip really into the misconceptions part, but recently I had a talk. Our school kind of had this thing where they kind of impressed upon the medical students that, hey, remember, you're not a tourist, no matter like where you go. in terms of the rotation that you're on. Like, say, for example, like, oh, I don't really want to do surgery. So I'm just gonna, yeah, like, meh my way through surgery and then see how it goes. How I guess finding that type of mindset, what is something that is special to peds that you feel like medical students who might be rotating through peds can really learn and apply to all sorts of specialties, no matter where they end up going?
That's a really good question. I think there are a couple of things to acknowledge there. Um, One is the imperfect structure of medical education. Um, by design, you are going to do things in medical training that you are not interested in. I had no interest in standing in an OR for 8 hours, like holding some object, like I didn't have an interest in that. Um, maybe okay, arguably like no one does, but that's what you have to do to become a surgeon, sure. Okay, so there's like validity to that. And um, but by design, I always have thought that medical training wasn't tailored enough to people's interests. But then the further I got in medical training, and especially now in chief year, seeing like the behind the scenes of uh medical systems and training, like um, residency programs. Uh, I don't see it feasibly being done any other way with the resources and like money and time that people have. So we're stuck with the system. So I want to acknowledge that. Um, and then to answer your question, um, one thing I think would be communication. So yeah, I could add this to general advice, or maybe yeah, sure. I can add this to the general advice section of my presentation. So, um, the thing I would take away is that communication is an intervention. So, what I mean by that is what I mean by intervention, to take a step back, in medicine, for those of you who are maybe like less familiar, um, treatment or whatever, like whatever you end up doing for a patient or family is going to be considered an intervention, right? Like whether you prescribe a medication, you I don't know, like you did something to help move care forward for a patient, that's an intervention. My mindset is that communication is an intervention, and clear communication, and the better your communication, the better the outcomes. We see that demonstrated with, for example, patients and families whose first language is not English, how we see um, outcomes of medical treatment and medical procedures um, be worse in patient populations where their first language isn't English. And that it correlates exactly with how often professional or medical interpreters are used. And when there are lapses in communication, things break down, and it's not the patient's fault. It's on us. Um, I'm going to relate that to pediatrics because in pediatrics, communication is key, and we code switch all the time, which I think that's the short answer to your question. That skill that could be applied to any other specialty is being intentional about who's in the room, how much they understand, where you're looking, where you're positioned, your language, and like everything about the encounter. Because educating and counseling your patient and family can change long-term outcomes dramatically. Um, and your specific approach in your language might change whether your patient is 10 years old and speaks English, but parents don't, or your patient is 2 years old with a single parent, or you're talking to a foster parent and there are two siblings there. I would not use the same language in all of those situations. to explain the same medical procedure. So um, maybe like one more way of saying that is like there is this emphasis of standardization, right? Like every patient or family should get the same thing, like the same quality of care. And yes, like yeah, I definitely don't disagree with that. But in terms of communicating things, you really should be mindful. You like, general advice, you should be mindful about your wording and language because communication can have an impact on everything that happens in the hospital and afterwards. Pediatricians are especially attuned to that.
Thank you.
I had a question kind of based on where I'm at in my medical school training. So, being in second year, I still have to take step and then we move on to rotations. There's this like misconception or kind of, I'm not sure if it's a misconception or just a a meme kind of joke trend that students, when they're on their peds rotation, have no idea what to do because a lot of our standardized patients are adults and not children. So, how would you say when you're rotating, um, one, transitioning to like how to tackle that kind of like difference in, as you mentioned, code switching with dealing with different patient age groups, and then what would you say helps a student stand out during a peds rotation when a lot of students are like jittery and uncomfortable and still trying to figure their way out in that?
Hmm. Just to clarify, are you talking more specifically on your rotations or during those like standardized exams?
During rotation, so when you're rotating in peds and you've never really had that much peds exposure.
Gotcha. Yeah, it is a challenging, like, okay, so speaking personally, I did not have like experience in pediatrics before medical school. Like I didn't work with kids. I didn't go to schools and like volunteer. I don't know. I didn't have a lot of experience with that. And that kind of resonates with me, like not really knowing how to approach specific types of conversations. Um, if you're on your rotations and you're working with pediatricians, I think it's safe to assume that you're working with people who can appreciate the same things that I was just saying. Um, Also, hopefully, um, not to generalize, I think people who go into pediatrics are generally more understanding of like people in general, and who they are and like where they're coming from. And my point is there probably won't be as much of an expectation that you um, like know exactly what to say at at any given time. Um, and so to answer your question, I think it would be good to like ask questions about those interactions to the people you're working with. And I think that in and of itself might help you stand out, at least as it relates to pediatricians. We would love to talk about that sort of stuff. Um, so, more specifically, like you might be able to imagine on your rotations, on your non-pediatrics rotations, you might be able to imagine many of the questions that come up and that you ask your team have more to do with like medical care and the treatment plan and like meds and procedures or specifics of like the diagnosis or whatever. Um, but in pediatrics, I would encourage you to ask questions about how to handle communication, how to handle talking to parents about a specific situation, right? How how can I tell these new parents that their child has this life-changing diagnosis? Um, and that's worth talking about. And you don't need to know, like, you don't have to have a great idea of how to do that to start that conversation. I think that it's part of our job to help you learn that. Um, and I would also encourage you to be reflective and um, really think about what, let's see, I want to be careful with my words. Like these harder conversations, right, that I'm alluding to. Um, I would encourage you to reflect on that and um, like how you feel when even thinking about those conversations and and learn from it and learn like with the people that you're working with in pediatrics. Like, how do I explain this diagnosis to a parent? How should I communicate this? Um, yeah, hopefully that helps you both learn and stand out, I guess. I hope that answers your question. I don't know if I got it specifically.
I think so. I think in general, there's just not a lot of advice about going to start your peds rotation. So it helps to have just even something to go off of. I think that definitely answered it though.
Yeah, it's hard. Peds is, it's like, I don't know, what do you say to a 5-year-old? Like, I don't know. I've met 5-year-olds who are as mature as like 10-year-olds and 10-year-olds who are as mature as 5-year-olds. Just like a lot of peds is just really starting clean with a clean slate and forming your own impression of the patient and family with the interactions that you yourself have experienced. But that's a good piece of advice. I should write that down. But it's like, it's like don't hear a one-liner about like a 2-year-old and then assume this family must think this about their 2-year-old just because of the age or something. Like every family is different. Family dynamics are very different. Kids' level of like anxiety in the healthcare system is different. Like everything is different. So um, form your own impression of the patient and family in front of you just based off of what you're seeing. So that would be that would be one piece of advice.
You talked earlier about having lots of opportunities to partner with the parents of your patients. And I was wondering, because I also have my peds rotation coming up, in what ways are creative ways that you partner with the parents to be able to get information, especially through a physical exam? What are some creative ways that you've done personally to be able to do that?
Okay. So this is maybe what will separate like people who are meant to be pediatricians, like myself, from everyone else. Uh, there are a few ways to answer that. One question you could ask yourself is like, how comfortable, like, how ridiculous are you willing to look in a clinical setting, to get what you want, like to get the information that you want? I'll give you an example. So um, several weeks ago, I was the attending in. So, as chief resident, we also spend some time as the attending in urgent care and the pediatric wards in the hospital. So several weeks ago, I want to say 1-year-old, a 1-year-old came in with parents. Family was Spanish speaking, so that kind of pushes this encounter into a whole different like realm of working with interpreters, and I can talk about that more if you want. But this 1-year-old was riding in a car. She was in the car seat in the back, and out of nowhere, she just started screaming and crying in the same way she does when she's in pain. No injury, no nothing that parents could. She was just sitting in the back calm and suddenly started crying. And she didn't stop. It scared the family so much that they brought her to urgent care because they thought that she was in pain because it looked like she was in pain. Her vital signs, right, like heart rate, blood pressure, those sort of things, respiratory rate, those were all abnormal. but it's because she was crying and screaming during the time that they were measuring vital signs. So an accurate exam is very important. I'm not going to get into what the differential might have been or possible diagnoses for like sudden screaming and crying. You can think about that as like a clinical exercise if you want. But the takeaway here is that an accurate exam is very important in figuring out whether or not the patient in front of you, or in this case, this 1-year-old, has a can't miss diagnosis. Um, one example, I need to mash on her belly to see if her belly is very painful and tender, to see if there's some sort of problem in her belly. But if you're screaming and crying, your belly is going to be tense no matter what, right? And so actually I'm smiling because like I remember the intern going in first. Um, she did great. Uh, it was a very challenging encounter, and she asked for backup, is how I put it. Um, we started dancing for this 1-year-old. We put on some music and we started dancing. And she wasn't really impressed, but she stopped crying. Um, and we did some other things too. I'm not going to get into it, but then, so my point is distraction. Distraction is everything. Okay, so that's like the takeaway from that whole story is distraction is everything, and there are so many ways to distract your patient. Um, and then once she was distracted, we could feel her belly, and it was soft and non-tender. So distraction, you can ask the family what their favorite TV show is, put it on their phone, put your phone up here so that you can auscultate the chest and they're not seeing the stethoscope. You could, um, oh, kids react to, kids' reactions are largely based off of like what they perceive as dangerous or new or threatening. And a lot of that is based on the reactions of other people that they've seen. Um, Examine the older sibling first, examine the parents first, stick the thing in your ear first, and pretend like they're looking into your ear so that they can see that it's not dangerous. And then stick it in their ear. And it works pretty well sometimes. Um, so yeah, it's kind of hard to say, like, put yourself in the shoes of a 1-year-old. Like, that's kind of vague and I don't think that's practical advice. But think about what, like, think about what a child would think about the things you are doing or saying, and then take it from there, I think is how I'd answer, right? Like, are you going to put on gloves first, or is that going to remind this 2-year-old of all the vaccines they've received over the last year? Maybe I'm not going to put on gloves as soon as I get into the room. Something like that. I don't know. So there are a lot of tricks. Distraction. One more. Distraction. Show them things are not dangerous. And then the third one, oh, oh, give them a choice. What really bothers children, and honestly, like many adults, is the lack of agency over small things. That can lead to like something like a tantrum, for example. Um, Giving kids a choice when in reality it doesn't really matter, can help calm them a lot and make the visit a lot easier. One example is when examining ears, which is oftentimes like the most difficult part of a toddler's examination. Give them a choice. Say like, should I examine this ear first or this ear first? And then they'll point to one ear and you'll look and it's fine because you are look to them, you're looking in that ear because they told you to. So when they have control, give control to your patient, even if it doesn't matter. Like I'm gonna examine both your ears. So those three things I think are pretty high yield.
Thank you so much.
And sometimes it's just impossible. Like you just got to do it quickly. If everything else fails, like just like ask the parent for help. Hold one arm around the arms, one arm around the head. Just do it. Just do it quickly and then just get it over with. Sometimes that's inevitable. So got to acknowledge that too.
I have a little bit of a fun question, but do you have a particular age group that you like working with the most in pediatrics? Like you've mentioned that you really love babies, so like is it the newborns in that phase? I'd talked to one pediatrician that particularly loved teenagers, which I thought was super interesting because that's usually not the age group I'd expect. So is there an age group that you particularly like working with the most?
Yeah, I love 4 to 6 months old, 4 to 6 month olds because um they're still a baby, so they're like really small, but they're really chunky. Kind of like with the rolls and stuff. And 6 months is usually before any sort of like stranger danger um starts to manifest, right? That's part of the reason why like 1 or 2 year olds are so difficult to examine, is because they don't want to have anything to do with you, right? But 4 to 6 month olds, they don't care. Um, it's still in that newborn phase where there's a lot of things to talk about for new parents, because I love working with new parents specifically. And I think I think that's about it. So like young infants, I guess, because they're really cute. Maybe this goes back to the thing I said about like find something that you can see yourself like going to every day, right? Long term. Um, Babies bring me joy, like kids bring me joy, and it's so much easier to go to work every day knowing that like your patients themselves are just gonna put a smile on your face just by like looking at them. That's really not, I can only speak for myself. That's just not true of every specialty. That's just not true for me personally. Teenagers, they're okay. They're all right. I think it depends. I think a large reason why I like hesitate to endorse a lot of satisfaction caring for teens is because of flaws in our system. The visits are not long enough. Like I need to talk to you. I need to get to know you more, to form a partnership with you. It's just like it's really hard. Like adequate um, healthcare for teenagers is pretty hard because of limitations in the system, and that's probably why I find it so challenging. I like babies more though.
All right. If there are no more further questions, again, thank you so much for your time. We really appreciate you being here and just answering all these questions, especially about the misconceptions. I feel like that's something that can be a little bit murky when it comes to the field of pediatrics, especially with everything that we hear like in med school and otherwise. But we appreciate your time and we would love if we could take a quick group picture if that's okay with you.
Yeah,
All
absolutely.
right, awesome. All right, if y'all could turn your cameras, if you're willing and able, we'll go ahead and take the picture. All right, 3, 2, 1. I think I was able to get it, but let me see. All right, yeah, we got one.
Yo,
Thank you so much.
are you in Seafood City?